All right, so this presentation is going to be taking us from slide 55 through the end of the presentation. We are going to be covering our psychotherapeutic medications, antidepressants, and mood stabilizer medications. What these drugs are, right, when you get into the cycle of depression, it can lead to anxiety, it can lead to panic, and then more depression, more anxiety, and it just keeps going around and around. So we're really wanting to disrupt that pattern for our patients. We are going to be talking about tricyclic antidepressants. This is one of our first generation um, antidepressant classes. These are medications that can cause significant sedation, orthostatic hypotension, decreased sexual desires and functioning, as well as dry mouth. That's one of the most commonly complained of symptoms with these medications. Anti-anxiety medications, these are anxiolytics. These include our TCAs. That first gen is hardly used anymore. This is our amitriptyline is going to be our most commonly one that is still administered here. This is also going to include buspirone. This is a medication that is different from benzos. It works on the serotonin and dopamine receptors and is indicated for the treatment of anxiety. This does need to be a scheduled medication, this buspirone. It's not an as-needed medication like our benzodiazepines or alprazolam, which can be used as needed for anxiety medications. Um, this whole the way that buspirone works is by reducing anxiety through reducing the overactivity of the CNS. All of these anti-anxiety medications, really the way they're working is by reducing the overactivity of the CNS systems. Our benzodiazepines or alprazolam can be useful for anxiety. It's also used to treat alcohol withdrawal and insomnia. It is also an adjunct therapy for depression, again, because depression and anxiety go together, they go hand in hand. These benzos are going to be contraindicated in pregnancy due to sedative and teratogenic effects. Our most common adverse effects with any of these medications are going to be an overexpression of their therapeutic effects. Especially benzodiazepines are going to be associated with CNS depression, hypotension. The most complained of side effects for our benzos or for any of these medications really are weight gain and sedation, lethargy. They often cause some GI upset. Overdosing with benzodiazepines, especially when combined with alcohol or other depressants, we're going to have some somnolence, confusion, coma, respiratory depression, and those are more likely to occur whenever we have a patient with renal failure. We are also going to be talking about our MAOIs and our second generation fluoxetine medications. All right, so our alprazolam or Xanax, this is one of our most commonly used medications. It's often used for panic disorders, general anxiety disorder. It is useful for short-term relief, is why we really like it. It has a very quick onset. Um, it can be used just whenever a patient is having a panic attack coming on, or if they know they're going into an anxiety producing environment, they can take this ahead of time. Um, it does have some adverse effects of confusion, headache, and ataxia. It is going to interact with alcohol and contraceptives. We also have lorazepam. It's a little bit more rapid. Its onset is 15 to 60 minutes, especially if you can give it in an IV form. Our TCAs, again, those are amitriptyline. Those are first generation antidepressants. We are no longer frequently giving these for antidepression because of significant cardiac dysrhythmias and cardiac effects, as well as an increased seizure risk. It also causes abnormal CNS effects. Does have very, very lethal overdose potential, especially when combined with alcohol. About 70 to 80% of those patients die before even reaching the hospital, especially if it's in conjunction with alcohol. It is still used to treat insomnia, neuropathic pain, and migraines. It does have potential and potent anticholinergic properties, which is part of how it's useful for migraines. It uh, is contraindicated in the presence of drug allergy, of course, pregnancy, as well as recent MI because of those cardiac effects that it has. You do also want to teach the patient that it discolors the urine, I believe orange, if I'm not mistaken. Our MAOIs, these are another first generation antidepressants. These are often used to treat Parkinson's. They do have a high potential for hypertensive crisis, especially when taken with stimulant medications or foods that are high in tyramine. Um, so this is all of the fun foods, right? This is going to be your cheese, your wines, your preserved meats. If you take a look at the list in your textbook, it is very extensive food interactions, and it's going to lead to that hypertensive crisis. That will be the patient will have sweating, tremors, elevated temperature, bounding heart rate, and very, very high blood pressure. Um, if their blood pressure is greater than 180 over 110, they do need to seek emergency treatment. When taken with over the counter medications, this can cause cardiovascular effects. When used in combination with SSRIs, they have increased risk for serotonin syndrome. If we are ever switching a patient from an SSRI to an MAOI or vice versa, we need at least 14 days between those drugs prior to switching. Our SSRIs, these are going to be our second generation medications. These are very useful for obsessive compulsive disorders, depression, and anxiety. We do need to monitor for headache. A lot of patients complain of nausea and lethargy and fatigue, as well as sexual dysfunction and weight gain. Patients very frequently will discontinue SSRIs because of their side effects, despite the fact that they are much preferred to MAOIs and TCAs because they do have a better adverse effect profile. They have significantly fewer effects, especially they don't have the anticholinergic and cardiovascular effects that we see with the MAOIs and TCAs. Um, However, they still do have a lot of side effects. And the most common ones that people will skip their medication because of, or just stop taking their medications altogether, are because of sexual dysfunction, weight gain, and the insomnia are some of the more common complaints. Our fluoxetine is going to be one of the most commonly prescribed, and it is the prototype drug for this class. Citalopram, or that Celexa, is going to be the most commonly used medication, but it does have a short half-life, and it is one of the medications in this class that is most frequently associated with discontinuation syndrome. Which we will talk about more in a moment. Fluoxetine, like I said, is our first SSRI and our prototype drug. Again, the reason we prefer these is because they do have a fewer adverse effects, especially the anticholinergic and cardiovascular effects. It does still take 4 to 6 weeks to reach maximum effectiveness, and I didn't talk about this yet. So any antidepressant is going to take about 4 to 6 weeks to take effect. We really need to be careful about educating our patients. They need to know that this is going to happen. Sometimes patients can actually have an increase in suicidal thoughts and suicidal ideations, especially within the first 7 to 10 days of starting an antidepressant. And that is when they are going to be that 4 to 6 week period of initiation of antidepressant therapy is going to be when they're at most risk for suicide attempts. So we absolutely need them to let us know if they are having any increase in suicidal thoughts, if they're having any increase in suicidal ideations. If so, we need to assess for whether or not they have a plan, how serious are they, and get them make sure we have appropriate treatment for them. If so, these suicidal thoughts are, especially with the SSRIs, are most noted in children and up to age 21, and especially in young males, we see a higher prevalence. These are going to be indicated primarily, we are going to use these primarily for depression. We can also use them for other mental and physical disorders, especially bipolar, obesity, OCD, PTSD, or PMDD, and substance abuse. These medications absolutely have to be tapered off and not stopped abruptly. That discontinuation syndrome will present like flu-like symptoms. They may feel faint or dizzy. They might have some GI symptoms or difficulty concentrating. They do need to notify their provider immediately if they notice this. Tapering off of these medications will help prevent this rather than stopping them abruptly. These medications are highly bound to albumin, especially when in conjunction with other highly bound protein bound medications, so our warfarin and phenytoin. This will lead to increased toxicity of these medications. Some of the adverse effects we can see, again, the most common and bothersome ones are that insomnia, weight gain, weight loss, and sexual dysfunction are the ones that are complained of the most. 2/3 of patients are actually going to DC their medications because of their adverse effects. Oftentimes, we can change which medication they are on, and they may have a better side effect profile as a result. Our St. John's wort, this is referred to as nature's Prozac. People often use it for sleep disorders and depression. It can cause some GI upset, some dizziness, confusion, dry mouth. It's going to interact with lots of medications and foods. It is contraindicated in bipolar, schizophrenia, as well as Alzheimer's and dementia, as well as it does have an adverse effect of photosensitivity, especially in fair-skinned individuals. We can potentially have some serotonin syndrome. This is when we have too much serotonin on board due to any drug that can cause serotogenic activity. So this is going to be table 16.5. You can find those drugs. But think about if you have a patient who is on fluoxetine or Prozac, as well as St. John's wort, because they don't realize that there's an increased risk for the serotonin syndrome. This is usually self-limiting when the patient discontinues the causative drugs. These symptoms will resolve. A lot of times we're going to see delirium, tachycardia, maybe some shivering, muscle spasms, sweating. They may be agitated. In more severe cases, they can have hyperthermia, renal failure, dysrhythmias, and seizures and death. Okay, another antidepressant here is bupropion or Wellbutrin. This is commonly prescribed for smoking cessation. This is not buspirone. So both of these are CNS drugs, but bupropion is an antidepressant that is used for smoking cessation. It is while our buspirone is an anxiolytic for anti-anxiety. Again, with our bupropion or Wellbutrin, this is a medication that does have a high risk for suicidal ideations and suicidal thoughts and attempts. They do need to report this immediately. It can also lower the seizure threshold. It has some adverse effects of dizziness, confusion, and tachycardia. Alcohol is going to be a CNS depressant. It can have lethal respiratory depression, like we've talked about. It interacts significantly with other medications. We can give disulfiram or Antabuse to help with alcohol withdrawal. Marijuana is going to be classified as a CNS depressant in some ways. It does help decrease pain and enhance calmness. Has the potential to decrease stroke and help with epilepsy. I have absolutely seen it used for hem-onc patients to improve their appetite as an appetite stimulant. It is absorbed in seconds if inhaled. It does cross the placenta and can be found in breast milk because it is lipophilic. It's metabolized by the liver and excreted primarily in the feces. It can cause some dizziness, tiredness, hallucinations, especially if in excess amounts. Long-term effects, we don't really have a good understanding of this. It interacts with anything that is going to also have additional CNS effects, would enhance its sedative effects. If it is taken by mouth, it can also interact with Benadryl and opioids. Your textbook has a lot more information about marijuana and alcohol, as well as their withdrawal, if you want to review that. whenever we have a patient who's taking antidepressants, we always need to do a comprehensive history as well as medication therapy. We want to know their potential for abuse. What do they do? Any other alcohol or drugs? We want to monitor for the therapeutic effect. Again, educating them that it is going to take 4 to 6 weeks to achieve that. While monitoring for adverse effects and the potential for stopping the medications because they are not liking the side effects that they are experiencing. We do want to educate them about the drug reactions, the food reactions, herbal reactions. Definitely pay attention to those in your textbook as far as what side effects and interactions can be experienced. Mood stabilizing agents. This is going to be our lithium. This is used to treat bipolar illness, especially manic episodes. It can be used for maintenance therapy to prevent those episodes as well. We don't fully understand how this is working in the body. Our serum levels do absolutely have to be managed and monitored. We wanted to keep it between 0.6 to 1.2 milliequivalents per liter. Its toxicity is going to be significantly increased by changes in fluid and sodium. So, because sodium and lithium ions affect one another, we really want to be careful to not drastically change the sodium intake. We want to avoid overhydration and dehydration again because of this. It is going to have that very narrow therapeutic range. It is going to be contraindicated in sodium imbalances, especially hyponatremia and hypovolemia. Any major renal or cardiac disorders, it will be a contraindication as well. Adverse effects are going to be primarily GI discomfort, but the cardiac dysrhythmias are going to be the most severe. We can also have some drowsiness, difficulty coordinating, tremors, muscle twitching. Its therapeutic range is going to be, like I said, 0.6 to 1.2 milliequivalents per liter. Short-term adverse effects include vomiting. It is going to be contraindicated with kidney damage. It can cause kidney damage with long-term use. And leading to high blood pressure and cardiac dysrhythmias. It is contraindicated with any NSAIDs, ACE inhibitors, and thiazide diuretics as well. All of those are going to increase lithium toxicity. All right, psychosis is going to be mental disorders characterized by disordered thought processes and often bizarre thinking. They may have hypo or hyperactivity, agitation, aggressiveness, social withdrawal. And these antipsychotic medications are also used to treat autism and extreme mania and bipolar disorder, as well as therapy-resistant depression. These psychosis is frequently treated with Haldol. This is our first generation and antipsychotic. Now we are moving towards atypical antipsychotics, especially risperidol or risperidone as one of the more commonly ones. This is an atypical medication that's very useful for schizophrenia. It has minimal extrapyramidal adverse effects. With our Haldol, we do need to be careful watching for neuroleptic malignant syndrome. They will experience a very high fever and unstable blood pressure. We do not want to use Haldol in older adults with dementia. That is going to have an increased risk for death, as well as increased risk for suicidal thoughts in children and young adults with the Haldol. Haldol is associated with extrapyramidal reactions. They can experience some tardive dyskinesia, which is involuntary tongue movements and facial twitching. That is more commonly associated with long-term antipsychotic therapy, as well as some uncontrollable body movements and maybe some vocal utterances as well. All right, that is the end of this recording. I will see all of you on Friday for our next lecture.